All right, well, I'd like to welcome everyone to our monthly seminar series here at the ICRN International Cholangiocarcinoma Research Foundation Network. It is such a pleasure for me today in particular to introduce Mark Yarchoan. Mark did his initial schooling at Amherst College and then moved on to the University of Pennsylvania to get his medical doctorate, residency, and then joined our fellowship at Johns Hopkins a few years ago. When Mark was doing his research time, he entered the laboratory working with Liz Jaffe, but really pioneering his own path, focusing on the tumor microenvironment and the immune biology of hepatocellular carcinoma and cholangiocarcinoma. And we were fortunate enough a couple of years ago to recruit him onto our faculty. Since that time, he's been extraordinarily productive, publishing important seminal papers, including in the New England Journal, JCI Insight, many different papers looking at the tumor microenvironment in GI cancers and really focusing on how we can use neoantigen expression to improve immunotherapy. At the same time, he's been very interested in the use of targeted agents and how these other classes of agents can be immunomodulatory as well. And so today he's going to talk to you about a clinical trial that he co-led over the course of both his fellowship and now facultyhood, looking at MEK inhibition and its potential role in cholangiocarcinoma. So Mark, welcome.
Thank you, Nilo, for the warm introduction. Let me just pull up my slides here. Can you just nod if you can see my slides? Okay, good. I'm always relieved when this works. So I'll be discussing today the topic of MEK inhibition for biliary tract cancers, reviewing the results of a clinical trial that actually Nilo and I co-led, and then also the direction of our laboratory research on the topic of MEK and cholangiocarcinoma, with a focus on the direction where we're headed. So first, just a little bit of housekeeping. These are my disclosures, and in particular, in case there are patients or providers on here, we will be discussing some off-label use of MEK inhibitors. So this is probably very basic for many people here, but I want to give just a brief introduction about biliary tract cancers. These are cancers that arise in the biliary epithelial cells that drain the liver. They're anatomically subdivided into intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. These three cancers are probably distinct, and as we've started to sequence these tumors, we've started to better understand the molecular differences between these tumors, but they're often grouped together because the treatment for them, at least in the frontline setting, has largely been the same. These cancers are generally considered to be rare, although they're certainly not rare in our clinical practice, because this is a lot of what we see. And the incidence of these tumors are increasing. Some of that may be driven by rising incidence of obesity, which seems to particularly be driving up the incidence of intrahepatic cholangiocarcinoma. Patients with cholangiocarcinomas are generally treated with frontline chemotherapy with gemcitabine and cisplatin. That's remained the standard of care for a long time, about a decade. But recently we've started sequencing these tumors and identifying actionable mutations in a subset of patients, mutations in FGFR2, IDH1, et cetera. These are particularly common in patients with intrahepatic cholangiocarcinoma, and these patients may benefit from targeted therapies. For patients who don't have targeted therapies, the standard of care right now is to treat patients with FOLFOX in the second-line setting. But the benefit there is quite small. We think the survival benefit is in a range of about a month. So clearly we need better treatments for this cancer, particularly in the second-line setting, where the standard of care right now for the majority of patients really has a very small clinical benefit. Obviously, immunotherapy has revolutionized the treatment of many different cancers. This is something that a lot of our patients are attuned to. But unfortunately, PD-1 or PD-L1 targeted checkpoint inhibitor therapy has quite limited activity in these biliary tract cancers. So this is just a basic chart of many of the trials that have already occurred of PD-1 or PD-L1 targeted immunotherapy in cholangiocarcinoma. And I have here the response rates. And you can see that in most of these trials, the response rates have hovered around 5 to 10%. So clearly there is a group of patients who respond to checkpoint inhibitor therapy, but the number of patients is relatively small. And I think that if you take these groups of patients who respond, this 5 to 10%, and you pull out particular subsets, so the mismatch repair deficient subset, we know that there's some responses there, the high tumor mutation burden subset. If you look at these at cholangiocarcinoma without those subsets, probably the response rate is even lower than this. So there are responses, but they're few and far between. Right now, there are several clinical trials that are ongoing of PD-1 or PD-L1 targeted immunotherapies combined with chemotherapy in the frontline setting for cholangiocarcinoma, so gemcitabine, cisplatin, plus minus drugs like pembrolizumab. These are large phase 3 trials. I think it's possible that these trials will be positive, but even if they're positive, I think that the clinical benefit is likely to not be that big because, again, we know that these agents are really only helping a small subset of patients. And so I think the focus of our group here at Hopkins with cholangiocarcinoma has been trying to take this fairly immune-resistant tumor and trying to understand how do we make immunotherapy work for this tumor? What do we need to do to change the tumor microenvironment so that this tumor responds similarly to other more inflamed tumor types? So first, I just want to highlight the challenge of immunotherapy for cholangiocarcinoma. This is a table of tumor mutation burden across all the major tumor types. This is data from Foundation Medicine, which is a company that, as many of you do know, sequences many, many tumors. And what you see is on the right, these are the more hypermutated tumors. They form in the setting of carcinogens like UV light or smoking, and they have a high percent of tumors with a tumor mutation burden of above 10%. And these are tumors where checkpoint inhibitor therapy is often effective. Cholangiocarcinoma, one of the immediate challenges that we have is that we're dealing with a relatively low tumor mutation burden. On average, it's about 2.2 mutations per megabase, which puts it right there with other tumors that also tend to be immune resistant, like prostate cancer or pancreatic cancer. So this may be one of the reasons why immunotherapy, at least thus far, has really been challenging for cholangiocarcinoma. Another biomarker of response to checkpoint inhibitor therapy is expression of PD-L1 in the tumor, which really reflects immune infiltration and adaptive immunity in the tumor. And on the right, we have the more inflamed tumor types where these tumors are often PD-L1 positive. Cholangiocarcinoma, only about 5% of these tumors are PD-L1 positive at baseline at the time of diagnosis. And that puts it right next to other traditionally immune-resistant tumors like pancreatic cancer. So again, I think we're really dealing with a challenge trying to make these tumors respond to immunotherapy because of inherent biology here. These are sort of traditionally cold tumor types. I'll just mention that this is a little bit of a tangent, but a lot of people think that tumor mutation burden and PD-L1 expression are two sides of the same coin. And I just like to correct people and point out that tumor mutation burden and PD-L1 status are actually relatively independent. So you can have hypermutated tumors that are not immune infiltrated. You can have infiltrated tumors that have low tumor mutation burden. Both of these biomarkers can predict tumors that respond to immunotherapy. And these biomarkers themselves are fairly uncorrelated across the entire spectrum of cancers and also within biliary tract cancers. And so cholangiocarcinoma is a cold tumor because it's both a low tumor mutation burden tumor and it's non-inflamed. And this is actually a retrospective data set that we analyzed here at Hopkins, looking at which tumors do or do not respond to immunotherapy. What we found are that hypermutated tumors, regardless of PD-L1 expression, do tend to respond. But for non-hypermutated tumors, the lower your PD-L1 expression is, the less likely you are to respond. And biliary tract cancers fall into this very non-inflamed subset here, which are particularly cold. So when we think about rational combination strategies for cholangiocarcinoma, I think it's not feasible to increase the tumor mutation burden of the tumor, because that's something inherent to the tumor. You can't change the genetics of the tumor. But I think that in theory, it should be possible to convert a non-inflamed tumor into an inflamed tumor. And so when we think about rational combination strategies, what we really aim to do is to somehow drive in CD8 T cells, drive up the expression of PD-L1, and make these tumors become more inflamed and more likely to benefit from checkpoint inhibitor therapy. And when I was an oncology fellow studying with Nilo, who got me interested in cholangiocarcinoma, there was a paper that came out from Ira Melman's group at Genentech, looking at MEK inhibitor therapy as a means of priming the tumor microenvironment for systemic immunotherapy. And what this group found was that if you give a pharmacologic MEK inhibitor to mice with CT26 tumor cells, which are a RAS-driven colon cancer tumor model, you really drive up the expression of the amount of CD8 T cells in the tumor. You also drive up MHC expression in the tumor, which of course presents HLA. And the group proposed that there seemed to be some synergy between MEK inhibitors and PD-L1 inhibitors in their mice. Both agents by themselves had some activity, but when you combine them, you could actually get some impressive efficacy, even some tumor clearance in a subset of the mice. And the group went on to try to understand mechanism. MEK inhibitors, of course, have pleiotropic effects. They affect both tumor cells and immune cells. But the group that worked on this paper really argued that the effect was due to MEK inhibitors working directly on T cells to block sort of exhaustive T cell death by inhibiting NIR77 and caspase activity. And so because MEK is downstream of TCR activation and T cells, they argued that these T cells don't become exhausted and can just keep killing tumor in the setting of PD-L1. We'll come back to this idea. I think the biology here is actually much more complicated, but there's also been, I think, a long-standing and growing appreciation that the MAP kinase pathway, which of course MEK is a critical gatekeeper of, is important for tumor evasion of the immune system. So I'll just present some data for this. So this is data from Young Lee and her colleagues who led the study of pembrolizumab in mismatch repair deficient colorectal cancer. And as you can see in this randomized frontline trial, in general, these patients actually do better with pembrolizumab than chemotherapy. And that benefit is seen in basically any way that you divide up the data, with the exception of KRAS positive or NRAS positive tumors. And this is a group of tumors that really seem to, if anything, do better with chemotherapy than checkpoint inhibitor therapy. It's a small group of patients. Again, this is a sort of post hoc analysis, so we should interpret this cautiously, but it's something that's been seen not just in this study, but multiple studies, that if you look at the KRAS mutated mismatch repair deficient tumors, they really do seem to respond not as well to immunotherapy as the KRAS or BRAF wild type tumors. So it suggests that this MAP kinase pathway may be in some way inducing immunosuppression in these RAS-driven or GI cancers. And cholangiocarcinoma is obviously a rare tumor. This is data from our collaborator, Greg Lisinski, who has possibly the largest biobank of cholangiocarcinoma cells. And again, he has cells, cell lines from a number of human patients. with a wide variety of mutations, expressing, a lot of the mutations that we see in our patients. And what he's found is that, again, you do find KRAS mutations in a subset of patients with cholangiocarcinoma, but even in patients who have other mutations, you often do see constitutive activation of the MAP kinase pathway, as you can see here with phospho-ERK staining of these tumors. And in fact, probably about half of these patients have some sort of activation of the MAP kinase pathway. And just thinking about the MAP kinase pathway as a driver of cholangiocarcinoma, there's been interest in targeting these tumors with MEK, which is of course a critical gatekeeper of the MAP kinase pathway. These are studies that were done from about 2010 to about 2015. There were a number of studies of MEK inhibitors as monotherapy in cholangiocarcinoma. And what you can see is there actually were some responses. This is a drug that's now known as binimetinib. And so there was some activity of MEK actually as a monotherapy in biliary tract cancers, but it wasn't quite enough to jump up and down about. And I think most of the drug companies after these trials focused more on the other tumor types. But there probably is some activity of MEK even as a monotherapy in cholangiocarcinoma. But probably not enough to be excited about. This is the results of the latest MEK monotherapy study in cholangiocarcinoma. These are patients with biliary tract cancer who in second line were randomized on the SWOG study to trametinib, which is a MEK inhibitor, versus just 5-FU or capecitabine. And what you can see is that the study was actually stopped due to futility. If anything, the chemotherapy with 5-FU or capecitabine seemed to be beating the MEK inhibitor. Response rates were low. It was about 8% with the trametinib. And so it just seemed unlikely that the study would be positive in the second line setting, and the trial was stopped. Beating 5-FU in the second line is a pretty low bar, because now we would actually use 5-FU oxaliplatin, and even that only has a 1-month survival benefit in the second line setting. So I think it's fair to say that MEK has some activity in cholangiocarcinoma. There are responses, but they're few and far between, and we need to do more to really improve outcomes in this cancer. So just to summarize the beginning part, because I know some people have joined a little bit late. So biliary tract cancers, again, are immune resistant. There's very limited activity of PD-1 or PD-L1 therapy by itself. MEK inhibitor therapy similarly has very limited activity by itself. But perhaps the combination of MEK plus PD-L1 could be more beneficial, because each of these drugs has some activity, and at least in preclinical models, there seems to be some synergy between MEK and PD-L1 in RAS-driven tumors. And so this hypothesis that MEK inhibitor therapy could sensitize cholangiocarcinoma to PD-1 or PD-L1 targeted therapy was the basis of a clinical trial that Neil Azad and I and many others were involved in for cholangiocarcinoma. So this is the design of our trial. This is CTEP 10139, run through the NCI and conducted through the Experimental Therapeutics Clinical Trial Network. So patients with advanced biliary tract cancer were randomized to atezolizumab as monotherapy, so PD-L1 inhibitor by itself, versus cobimetinib plus atezolizumab, and followed until progression or intolerance. This is a fairly straightforward clinical trial design. Patients had to be above the age of 18, have reasonable performance status, and had to have pathologically confirmed biliary tract cancer, receiving at least 1 and actually up to 2 prior lines of systemic therapy. So some of these patients had, for example, gemcitabine, cisplatin, FOLFOX, for example. And the only stratification was by site of disease, so intrahepatic, extrahepatic, or gallbladder. And the primary outcome was progression-free survival. These are the baseline characteristics of the study. So we enrolled a total of 86 patients, of whom 78 patients were randomized. So 39 received the Arm A, which was atezolizumab. 38 received Arm B, which was the combination. And you can see that the patients were pretty evenly distributed between the two groups. Most of the patients, I don't know how to keep this thing from advancing, I apologize. Most of the patients had intrahepatic cholangiocarcinoma. We had some gallbladder and some extrahepatic as well. And you can see that there was a mix of first line and second line patients. Obviously, mismatch repair deficient tumors are more likely to respond to immunotherapy, and there was one patient in each group with mismatch repair deficiency. So this is the main result of our trial. So the primary outcome was progression-free survival. And actually, technically, this was a positive study. We met our primary endpoint of showing improved progression-free survival with combination therapy versus atezolizumab monotherapy. And so we actually approximately doubled progression-free survival from about 1.9 months up to about 3.7 months. But you know, again, this was not a jump up and down trial. You know, the progression-free survival was quite short in both arms. And then in subgroup analysis, and this is a post hoc analysis, it seemed to us that really the one group that seemed to benefit from combination therapy was actually the intrahepatic cholangiocarcinoma arm. This group had a median progression-free survival of about 4.5 months. All the other groups, regardless of group assignment, seemed to be closer to about 2 months. Again, these are small numbers of patients. This is a post hoc analysis, so I wouldn't read too much into it. So just advancing into secondary analyses here. So this was, I think, a bit disappointing to us. There was only one true objective response per arm. This is the waterfall plot here of the monotherapy group and the combination group with the one responder in each group in blue. So the progression-free survival benefit in the combination arm was really driven by a group of patients who had stable disease and not true responses. You can see the disease control rate was about 50% in the combination arm versus about 32% in the single arm. We did follow biomarkers, and this is the CA19-9 trend. As you can see, patients in the combination group seem to have more patients with declines in their CA19-9. Some of these patients didn't quite meet partial response by RECIST 1.1, but their tumors did seem to be responding somewhat. We also looked at overall survival. This was not a primary outcome of our study. And again, our trial was clearly underpowered for this kind of analysis, but what I would say is that there didn't seem to be any overall survival benefit for the combination arm versus the monotherapy arm. The overall survival numbers were similar in the two groups, 5.6 months versus 5.2 months. So again, a positive study, but we did not meet overall survival benefit. How about toxicity? Obviously a concern for any therapies, but a lot of these patients with biliary tract cancer are already quite ill coming in and may have different tolerance of these therapies versus other tumor types where this combination has been studied. So we were very interested in this. Actually, I think overall, these treatments were fairly well tolerated. You can see that there was more diarrhea, nausea, vomiting, and rash and cytopenias in the arm that got the MEK inhibitor plus PD-L1 versus PD-L1 by itself. But overall, the adverse events were not particularly dissimilar in the two arms. We did see that there were a number of patients in the combination arm who discontinued therapy very, very early on, so in the first week or so. This seemed to be driven by patients who were getting nausea, vomiting, diarrhea. So about 22% discontinued for adverse events in the combination arm versus 10.3% of patients in the monotherapy arm. So this wasn't actually statistically significant, but certainly a signal that there were a group of patients who had adverse events leading to discontinuation in the combination arm. So when we launched this trial, only the phase 1 study of Cobi Atezo had been conducted. But at the time that we did the study, or shortly after we opened the study, a number of other studies were published of the combination of MEK inhibitor plus PD-1 or PD-L1 therapy. And so I just want to just talk a little bit about our trial in the context of other clinical studies, because I think it provides some context. So cholangiocarcinoma shares some attributions with colorectal cancer, and the combination of MEK plus PD-L1 was studied in colorectal cancer, and this was also, I think, while our study was technically positive, this was technically negative as a study. The combination of Atezo plus Cobi failed to beat regorafenib, which was the standard of care. You can see that there seemed to be maybe an advantage to Cobi Atezo versus Atezo monotherapy in this study, but again, not enough activity to jump up and down and get excited about. So what I would say is that similar to our study, the study suggested that perhaps Cobi Atezo is not enough to transform a cold tumor into an immune responsive tumor. And then I think probably most disappointing was the phase 3 trial of this combination in melanoma, which was reported later. This is the IMspire 170 study, and patients were randomized to a checkpoint inhibitor by itself, which is pembrolizumab, versus Cobi atezolizumab and BRAF V600E wild type melanoma. And this was a negative study. What I would say is that this is actually a remarkably negative study, because if anything, the checkpoint inhibitor by itself seemed to do better, particularly at the tail of the curve versus the combination arm. And this is, I think, very interesting because unlike the colorectal cancer or the cholangiocarcinoma, this is an immune responsive tumor type where checkpoint inhibitors really have activity by themselves. And although cobimetinib is mostly used for BRAF V600E mutated melanoma, there actually is data of MEK inhibitors in this group of patients. So a lot of these patients have, for example, NRAS mutations, and there actually is activity of MEK in this group. So what we see here is we see two therapies, both of which probably have some activity, if anything, losing to one therapy. I don't want to overinterpret these data, it's just a negative study, but it really challenges the idea that MEK inhibitor therapy is helping immune responses. If anything, I think when we look at this, the signal is that maybe MEK inhibitors is somehow dampening our immune responses. And if you look at response rates, the response rate was about 37% for pembrolizumab versus about 28% for cholangiocarcinoma, an odds ratio of 0.67 in this study, which again is concerning because the MEK inhibitor should have some single agent activity alone in this group. Now, the checkpoint inhibitors in this study are not the same, right? Pembrolizumab is a PD-1 inhibitor, atezolizumab is a PD-L1 inhibitor. Maybe the PD-L2, PD-1 axis is important in melanoma and not blocked by atezolizumab. There are also some drug differences. A lot of patients do develop, for example, anti-drug antibodies with atezolizumab. So perhaps this disappointing trial could have been driven by differences in the checkpoint inhibitor, but it does really make you question the idea that MEK inhibitor is doing what we hoped it would do in terms of reprogramming the tumor immune microenvironment. Also, at about the time that we launched our study, there was a serial biopsy cohort of patients treated with cobimetinib by itself, just to see if the biology here was correct, because in the mouse models, we saw this big increase in CD8 T cells. And actually, the serial biopsy study suggested that indeed, if you treat with MEK inhibitors, you do seem to increase the CD8 T cell infiltration in tumors. This is, again, the results of 14 patients from the phase 1 study. 11 of the 14 had an increase in CD8 T cell infiltration. These are example immunohistochemistry before and after cobimetinib in that study. So again, we have a negative clinical result, but the biopsy studies did seem to suggest that maybe CD8 T cells are going up. And we've started to look at the samples from our trial. And again, you do see that the number of patients in the combination arm who had an increase in CD8 to FOXP3 ratio was higher with combination than in the single arm group. And I see a message here that someone's having trouble seeing my slides. Can you guys see my slides?
Now they're gone.
They're gone?
It says.
Well, that's not good. Let's see.
But somebody else says I can see them. Stacy says she can see.
Well, we'll just try playing it again. I'm going to close the program and restart. I apologize, everyone. Let's try this again. It's strange that it would have been working the whole time until then, but what can we do? All right, let's try this again. Can you see my slides here?
Yes.
All right. Got a lot more to cover, so let's hope this works. We're getting to the good part. All right, can everyone see my slides still?
Yes.
Fantastic. All right. So just to, again, refresh the results of our clinical trials. So in our study of MEK plus PD-L1 in biliary tract cancer, we did prolong progression-free survival compared to atezolizumab as monotherapy. This is a positive study. We almost doubled progression-free survival. But I think that the low response rates in both arms at less than 5% really highlights how challenging it is to make these tumors respond to immunotherapy, and probably to reach the point of clinical excitement, we really need to get our response rates higher. The combination was had manageable toxicity, and so I think it could be the basis of other combination strategies. And I would say, and this is again maybe a bit controversial, but I would say that the totality of the clinical evidence across not only our study, but also the studies in colorectal cancer and in melanoma really do not seem to show clear evidence of synergy. And so I would say that this is a failure to translate the preclinical findings of MEK plus PD-L1. So when we think about combination strategies, of course, our goal is always to develop synergistic combinations. And again, there's preclinical reasons to think that this is synergistic. We're overcoming MAP kinase mediated immunosuppression. We're driving up CD8 T cell infiltration in the biopsy studies. And then at least there's reason to think that things are additive because MEK and PD-L1 work through totally different pathways and may both improve anti-tumor immunity. MEK working through targeted therapy, PD-L1 converting these therapies, these responses into longer-lived responses. And I would say that most of our combinations right now of immunotherapy are sort of irrationally rational combinations like chemotherapy and PD-1 and PD-L1. But really, you know, we have to think about this in the context of the clinical data. The clinical data are disappointing because we don't see, at least in the melanoma data, for example, it almost seems like these are antagonistic. And so maybe we're missing something. And so when things don't pan out quite as well as you hope in the clinic, or when you want to make something work better, you go back to the lab and you continue to study the biology, and that is what we've done. So this is for the latter part of my talk. I'm going to focus on research done from Lauren Dennison, who's a graduate student working with me and Dr. Liz Jaffe, who's my own laboratory mentor, really trying to understand better, you know, how it is that MEK inhibitor therapy is changing the tumor immune microenvironment and what is preventing this from working better. And so in her first week in the lab with me, she did an experiment that I really think is very clean and highlights something interesting about the biology here. She took epithelial cells and grew them in increasing concentrations of EGF, which actually dials up the MAP kinase pathway in this cell line. And what she showed is that as you dial up the amount of EGF in the media, simulating more and more MAP kinase pathway activation, you suppress MHC. And so this is potentially, again, why KRAS mutated mismatch repair deficient colorectal cancer may be immune resistant. And then if you give a MEK inhibitor, you can actually reverse this phenotype and rescue MHC expression. And actually the amount of rescue is highest in the group with the highest amount of MAP kinase signaling. And so at least this portion of the biology does seem to check out that MEK inhibitors can reverse MAP kinase mediated immune suppression in the tumor. And to really get at mechanism, she went on to knock out MEK1 from CT26 colon cancer cells. This is a RAS-driven colon cancer model. And in every clone that she looked at, when she knocked MEK1 out, she augmented MHC expression versus the wild type cells, as well as MHC2 expression. I think this is a bit of a tangent, but what's interesting is that there are actually three MEKs. MEK1 may be the most important one. If you knock MEK1 out, MEK2 can compensate, and so you actually continue to see ERK activation because of compensation from MEK2. But knocking MEK1 out is by itself enough to rescue MHC, and so it suggests that the effects of MEK inhibitors are not just blocking ERK, that there's probably some other protein-protein interactions mediating this effect on MHC. And then she took her MEK1 knockout cells and grew them in a petri dish, and the cells grew spectacularly as though there was nothing wrong at all with them, which suggests that MEK1 is dispensable for tumor growth. And then she took her cells and she put them into a RAG knockout mouse, which is immune suppressed mouse. It doesn't have B and T cells, and what she found is that the MEK1 knockout cells, the tumors grew just as well if they had MEK1 as if they didn't have MEK1. So MEK1 again was totally dispensable for tumor growth. And then she put these same cells, implanted them into an immune competent mouse. And what you see here, looking at the red and black lines, is that the MEK1 knockout tumors grow much slower in an immune competent mouse. And so what this shows, I think, very cleanly is that MEK inhibition in tumors does delay tumor growth, and it does so in an immune-dependent manner. And so really MEK inhibitors do seem to have some very powerful immune effects on tumor cells. And then she went on to try to understand the mechanism here. Why is it that these MEK1 knockout tumors are growing so much slower in these immune-competent mouse? And what she found was that they indeed have higher concentration of CD8 T cells in their tumor, and these T cells are not only more active, as shown by increased expression of intracellular cytokines like interferon gamma and granzyme, but they actually are shifted towards a central memory and effector memory phenotype, and have less naive T cells in the tumor. So again, really powerful reprogramming of the tumor immune microenvironment by knocking MEK1 out in the tumor. And those were subcutaneous tumors. She also looked at a model of liver metastatic disease. So she injected these wild type versus MEK1 knockout cells into the spleen, where they metastasized to the liver. And you can see just gross differences in the wild type versus the MEK1 knockout cells. She didn't want to compare day 20 because at this point there's such a difference in tumor volume between the two groups that it wouldn't be fair to compare these groups. So she looked at an earlier time point at day 9 before there were gross tumors, and found that there were way more CD8 T cells in the MEK1 knockout metastatic livers than in the wild type livers, again suggesting that this could be the means that these tumors were cleared, again highlighting just how much these cells were reprogrammed. So what's the mechanism? What happens downstream of MEK1 knockout? So this is RNA sequencing of bulk RNA sequencing of the MEK1 knockout versus wild type cells. And what you can see is that there really is upregulation of JAK-STAT signaling and antigen presentation pathways in the MEK1 knockout tumors versus the wild type tumors. Some of the most differentially expressed genes actually in the MEK1 knockout group are genes involved in antigen processing and presentation, including HLA. And so again, really seems like MEK1 is a master regulator of antigen processing and presentation. And just to confirm that the mechanism through which these MEK1 knockout tumors were so much more amenable to immune control was through this JAK-STAT and antigen presentation process. She took her MEK1 tumor cells and exposed them to ruxolitinib, which many of you know is a JAK-STAT inhibitor. And at least the effect on MHC1 in vitro was at least partially dependent on JAK-STAT signaling. If you put ruxolitinib on these cells, you can reverse the upregulation in MHC1, not quite to the point of the wild type cells, but part of the way there. And then she dosed these cells systemic. So she actually implanted these tumors and gave these mice systemic ruxolitinib. And what she found was that systemic ruxolitinib really blunted the positive effects of MEK1 knockout on the on not only tumor growth, but also on the phenotype of the T cells in the tumor. So again, just to summarize, MEK1 really seems to be important for antigen processing and presentation, providing some mechanism through which MEK1 may be a really important immunomodulatory target. So again, we started scratching our heads. We're seeing all this beautiful data with MEK1 knockouts, but you look at the clinical data with cobimetinib, and it's just not quite as nice as what we hope to see. So we started wondering, maybe there's a difference between knocking MEK1 out of the tumor and giving a pharmacologic MEK inhibitor. If you give cobimetinib, you block MEK not only in the tumor, but also in the T cells. And so maybe we're having some other effect on the T cells. So Lauren went on to dose mice bearing CT26 tumors with cobimetinib, the systemic MEK inhibitor. And actually, she got completely different results than the MEK1 knockout in the tumor cells, whereas MEK1 knockout in tumor cells had augmented CD8 effector function. Pharmacologic MEK inhibitor was actually blunting interferon gamma, granzyme B, and TNF alpha in the tumor cells. And she actually repeated this in another model, in the panko2 model, which is a model of pancreas cancer that's also driven by the MAP kinase pathway, and similarly saw some blunting of the CD8 T cells. And so it suggests that MEK inhibitors may actually have a detrimental effect on T cell function. And looking at the phenotype of the immune cells, so you'll remember when you knock MEK1 out of tumor cells, you saw increased central memory and effector memory cells. When you give pharmacologic MEK inhibitor therapy, you see actually a higher number of naive T cells in the tumor. And then just to really understand this better, she took the CT26 model and put them into RAG knockout mice, as well as immune competent mice. And what she basically found was that MEK inhibitors, when you give them systemically, unlike the MEK1 knockout that we had studied previously, this is really working as a targeted therapy. So the benefit of cobimetinib systemically seemed to be exactly the same in an immune competent mouse as an immune compromised mouse. And so really these events are, this data is completely different than if you knock MEK1 out of the tumor cell. And this is just to, I guess, reiterate this point one more time, putting the data side by side. Here in black are the wild type CT26 cells, and you can see this is baseline. Looking at the expression of intracellular cytokines upon stimulation of TIL. And what you can see is that in the group that has MEK1 knocked out of the tumor, which is in blue, you see this very nice increase in interferon gamma and granzyme B. in the group that gets pharmacologic MEK inhibitor therapy, actually you see less interferon gamma, not only than the MEK1 knockout, but even less than the wild type. And so there's really a different result if you give pharmacologic MEK inhibitor versus knock MEK1 out of the tumor. So we wanted to confirm our findings using our clinical data and actually the specimens from our trial. And so our trial, again, had cobimetinib in one arm and no cobimetinib in the other arm. So it allowed us to specifically isolate the effect of MEK inhibitors on T cell function. And this is work from Greg Lisinski and a graduate student working with him, Amanda, who looked at the activation of peripheral lymphocytes from the trial. And sure enough, just as we had seen in the mouse models, the patients who got cobimetinib actually had less active T cells as measured by CD38 expression. And so again, this reiterates what we saw, that pharmacologic MEK inhibitor seems to be impairing T cell activation. So we went back to our mice and tried to see, could we rescue T cell function in the setting of MEK inhibitor therapy? And so we added in an agonist therapy, in this case 4-1BB, which works independently of the MAP kinase pathway in T cells. And in vitro, when we gave 4-1BB, we were able to rescue T cell function in the group receiving cobimetinib, showing that whatever detrimental effect cobimetinib has is reversible with an agonist therapy. And then we studied this triple combination in the mice, sort of a busy slide, and I'll just summarize quickly because I know we're short on time. But what you can see is the addition of 4-1BB reversed the MEK-mediated immunosuppression in the tumor, leading to not only higher numbers of CD8 T cells in the tumor, but higher expression of intracellular cytokines staining. And then perhaps most importantly, the mice that got the triple combination of MEK inhibitor plus PD-1 plus 4-1BB had by far the best survival of any of the groups. And so just to summarize our clinical back to benchside understanding of MEK biology, if you knock MEK1 out of a tumor, you really augment antigen processing and presentation, making these tumor cells much more amenable to T cell killing. But if you give pharmacologic MEK inhibitor therapy with cobimetinib, you have this, what I'll call a side effect, so a detrimental effect on T cell priming and activation. But this detrimental effect on T cells can actually be overcome by adding in a third agent, 4-1BB, that works independently of MEK to activate T cells. So this is a concept that we really want to move forward into the clinic. We studied 4-1BB because there's a wonderful mouse antibody available, but really thinking about translating this back into patients, we thought that really any agonist therapy would be reasonable to try in a patient, because all these therapies probably work independently of the MAP kinase pathway and may be able to rescue T cell function. And of particular interest was CD27, because as I showed in the prior slides, the MEK inhibitor treated mice had higher numbers of naive T cells, which express very high levels of CD27. And sure enough, just looking at expression in the mice, the combination of MEK plus PD-L1 led to an increase in CD27. Sorry, this should be down here, I apologize. 2.6-fold higher CD27. And so we've presented this back to CTEP, and encouragingly have had approval of the next generation clinical trial. This is going to be led by Thatcher Human, who's an oncology fellow here, following a path that I led years ago with Neil Ozad, who's our fearless leader of our clinical program here, looking at the combination of anti-PD-L1 plus CD27 plus MEK inhibitor versus PD-L1 plus CD27, really trying to understand whether the mouse findings are correct, that the reason that MEK plus PD-L1 wasn't as successful as we had hoped is that the T cells are impaired, but that this is rescuable with an agonist therapy. So this trial will hopefully start soon. It will have the co-primary endpoints of objective response rate and PFS. And really what we hope to see is increasing the response rate up to about 20%, which we think would be much more clinically meaningful than the 5% that we saw in our trial. So just to summarize, and then with the remaining time, I'd be delighted to take some questions. What I would say is that cobimetinib plus atezolizumab is tolerable. It prolongs PFS, but objective response rates are low. Preclinical data does support that MEK inhibitor therapy can reprogram the tumor immune microenvironment, but pharmacologic MEK inhibitor therapy is counteracted by detrimental effects on T cell activation, which is reversible with an agonist therapy, which really highlights the potential role for a triplet therapy. And, you know, I think that when we think about these very immunosuppressed tumor types, these immune-resistant tumor types, it's going to take multiple therapies in combination to get these tumor types to respond. And so I don't think we should be scared about trying triplet therapies in tumors like cholangiocarcinoma to really advance the speed of progress. And I'm delighted that we're able to move this concept forward. I just want to quickly acknowledge the clinical trial that I presented, CTEP 10139. This was a national study with many, many different site PIs who all contributed enormously to the study. Some of you may be on this call, and also the patients and their families for bravely participating in this study. And then I just want to acknowledge a couple of people. So I'm a fairly junior investigator, and I think most junior investigators like me are delighted if they have one mentor who really cares about them. And I am lucky to say that I really have three. Liz Jaffe has been my primary laboratory mentor, and Dan Laheru and Nilo have been my primary clinical mentors, and I'm immensely grateful to all the help that they've provided me. The preclinical work that I showed, most of that was led by Lauren Dennison, who is my very first graduate student. I co-mentor her with Liz Jaffe, and she's a brave person to work with a junior person like me. So I'm very grateful for all that she's done. And then Greg Lisinski and Amanda Ruggieri are at Emory and have been our very close collaborators on the CTEP 10139 study. We actually share an R01 with them and are delighted to push the science forward for our patients. And then I've highlighted a couple of people here who also contributed to the figures that I showed. So thank you very much for your time, and I'm delighted to take some questions in the time that we have left.
Mark, that was a fantastic talk. I'm a little biased, but only a little. Maybe we can look in the chat, or if anyone wants to unmute themselves.
All right, so first question I see here is about molecular profiling of the tumors. So we have molecular subtyping of a subset of patients, not all of them. Actually, that's something we've talked about for the next generation trial, really making that for all the patients. You know, I think when you look at the data, the PFS data looks similar in our trial to second-line FOLFOX, but I think one of the criticisms is a higher percent of our patients were intrahepatic cholangiocarcinoma, and as you pointed out, this may have included a higher number of patients with FGFR or IDH mutations who have better prognoses. So perhaps some of the PFS, reason that our PFS looked as good or better than FOLFOX was just driven by differences in the groups that we put on. So certainly it's a good point. I think that really since our trial was launched, sequencing has become even more important for cholangiocarcinoma and is obviously the standard of care now. Let's see. Is the immune effect of MEK1 inhibition similar for intrahepatic versus extrahepatic cholangiocarcinoma? So I don't think we know that answer yet. What I would say is that we've really been working with a variety of MAP kinase-driven tumor models. So the biology here probably applies to multiple GI tumors. But as you know, we really have a challenge in cholangiocarcinoma with preclinical models. We really don't have many models distinguishing intrahepatic and extrahepatic cholangio.
Mark, I'm going to bring up the sequencing question again because I read it a little bit differently. I think that the question may be speaking to how we sequence therapy and the different effects of giving something first versus second.
Ah, okay. That makes sense. You know, at the time that we did this study, none of the FGFR inhibitors or IDH1 inhibitors were NCC unlisted or approved. And so I think it was a very small percent of patients. I don't know the exact percent that got FGFR inhibitors. Neil, I don't know if you want to address it as the overall clinical PI.
Yeah, I mean, I think, of course, at that time, we didn't have that knowledge, and those were only on clinical trials. And our present study is going to shuttle people towards FGFR inhibitors first if they qualify rather than doing this trial. I think the other piece of that question was just the idea that the MEK inhibitor itself, if you give it first, is it more immunomodulatory versus if you give it after the immunotherapy? How do you sequence the agonist agent with the PD-L1 agent? And so I think those questions are very important and are absolutely what Mark and his team are working on in the clinic, in the lab as well.
All right. And I see a question here from Adam Deal. That name is very familiar to me. Adam, I hope you're doing well. So in the Checkmate 142 study from Young Lee, it looks like although response rates were lower in mutant versus wild type, this was not true with the Nivo-Ipi arm. Would you consider PD-1 CTLA-4 combined with MEK inhibitor therapy? So actually that triplet, it's interesting. There is data for PD-1 CTLA-4 plus MEK in pancreas cancer. And there does seem to be some activity there. The question is whether CTLA-4 itself is enough to activate these T cells even in the setting of MEK inhibitor therapy. And so I think it's a very good question and an intriguing idea. My understanding is that other studies are actually planned with that triplet.
All right, well, I think we're coming on the 2 o'clock hour, so I'm going to thank Mark and all of our participants for joining us, and we will see you next month.
Thank you, everyone.